Welcome to this episode of ASNC's interview series, SPECT MPI, Best Practices, Progress, and Pearls. I am Roxana Campisi, ASNC board member, Associate Editor of JNC, Chief of Nuclear Cardiology at the Instituto del Diagnóstico and staff at Diagnóstico Nuclear in Buenos Aires, Argentina, with my co-interviewer, Dr. Talal Asif. Talal, would you like to introduce yourself?
Yes. Hi, my name is Dr. Talal Asif. I'm an advanced imaging cardiologist at University Health in Kansas City and an ASNC leadership development program member.
Thank you, Talal. Dr. Duvall, member of the ASNC board, professor of medicine at the University of Connecticut School of Medicine, and director of nuclear cardiology at Harvard Hospital, joins us today to share his expertise on this topic. Thank you, Dr. Duvall, for joining us.
Oh, thank you so much, Dr. Campisi and Dr. Asif and ASNC for having me here today. And I really look forward to our conversation this morning.
Okay, thank you, Lane. We will move now for the first question of this interview. Lane, SPECT remains the most widely used modality in nuclear cardiology. In your view, in your opinion, what are the top 3 factors contributing to its continued clinical relevance?
That's a great question. SPECT is sort of the grandparent of imaging. It's been around for such a long time, and everyone is familiar with it. I think its main strength is really its availability. Dr. Andrew Einstein and his group had a wonderful paper out recently looking at trends in imaging volumes over the last 10 to 15 years. And we can see from that work that SPECT really is a test that it's performed in the millions of studies per year. That means it's available, it's out there, it's in every private cardiology office, it's accessible to our patients. And that availability is a great strength in this day and age of difficult access to healthcare. So when you can get an important non-invasive test that assesses for the presence of coronary disease, just around the corner from where you live, that's a real strength of the modality. You don't have to travel hours and hours to a major medical center for it. You can get it locally in your community. Because it's been around for so long and because it's ubiquitous, the cost of SPECT is relatively reasonable compared to the other higher price imaging modalities or studies that involved new and expensive tracers. So I think the cost effectiveness of the modality and the information we get out of it for that price is very important as well. And third, I think it's familiar. We have comfort with the test, and more importantly, the providers that order the test, be them primary care providers or advanced practitioners. Everybody knows what the test is. They know how to prepare a patient for it. They know what to do with the results that they get from the test. And this comfort, is a double-edged sword. It's good and bad for us. It's not so great because, the reputation of SPECT imaging is that not of nuclear medicine, but of unclear medicine. And that's not great for us, but it is a realistic expectation of what you're getting out of SPECT. People know its strengths and its weaknesses. So that comfort, I think, is also a plus for us. Providers know that they can order the test, they know what to do with the results, they can get it quickly, they can really help manage their patients, and they have that experience over the years. So I think those are the 3 big things really continuing to drive SPECT use in the US.
Thank you, Dr. Duvall. ASNC recently released 44 quality metrics for nuclear cardiology. Which of these do you consider the most actionable for improving lab performance, especially in relation to common challenges such as attenuation artifacts or imaging high BMI patients?
Wow, that's a big question. I mean, this was an incredibly thorough, dense, well thought out information statement that ASNC put out. I mean, so many people were involved in the process of writing this document, and it is really comprehensive. So if you want to really measure how well your lab is doing to universal standards, you can do that with this document. As you said, there are 44 quality metrics, 8 axes. It's incredibly thorough. So it's a big question to ask, what is the most important one in here to improve your lab's performance? And I want to narrow it down to that question of performance. And I think performance in a spec lab has everything to do with the quality of your image acquisition and processing, because without that quality, what you interpret as the physician after everything's done is either garbage in, garbage out, or it's high quality images with high quality results. So I think those metrics on this guideline that deal with imaging are the most important. And I look towards the use of attenuation correction as a metric that comes in there twice. And we say attenuation correction, oh my, that involves more expense, more time. I can't do that in my lab if I'm not doing it now. And that's not true. You don't need anything new. Any lab can do 2-position imaging, supine and prone imaging, and improve their image quality. As a result, you don't have to have a CT scanner for CT attenuation, or a scanning line source, or a fancy new camera with AI attenuation correction. So I think that small aspect that only adds a few minutes to the scan time can really help with your quality. Next, a whole axis on processing, I think, is very important. And that axis looks at reducing extracardiac activity, making sure patient motion is reduced, making sure your contours are correct, using iterative reconstruction. I mean, that's 25 years old at this point. You should have iterative reconstruction. And then quite a number of quality control aids that they step through on your processing and review of the images, everything from looking at your cine images to your axis of orientation. Again, if you don't have a good quality image, you're not going to have a good quality interpretation, and you're going to have false positives and false negatives as a result. So that image acquisition and processing is very important. The last thing I would say goes into the category of the age of the instrumentation. A lot has changed in the last few decades, but many people still have cameras that are decades or 20 years old. Those cameras still work, they still produce images, but there have been a lot of technological improvements in both the software and the camera hardware, moving towards solid state, high efficiency cameras that are going to make the new camera so much better than the old one. And I know that's not an easy thing to do. It involves costs, but it is really a big step in improving quality in someone's lab.
Thanks, Lane. We'll now continue with the next question. Imaging interpretation goes beyond reading just the polar map. How do you personally integrate perfusion, function, stress test result, and cardiovascular risk in your report?
So an excellent question. I'm fortunate enough, or on some days I feel less fortunate, but we read all of our studies here with our fellows. And I think teaching the next generation of cardiologists is very important to keep you on your toes. And it also means that we try to read things the same way and go over all of our studies the same way, because just like you read an EKG or a chest x-ray the same way every time, we try to have a pattern to how we read. And our reading sessions start with discussing the case first. We talk about the patient, why they're here, what they've had done in the past, and what they did today in the stress lab. Did they exercise? Did they have a pharmacologic study? What kind of symptoms did they have? And what their EKG do? I know people that believe in just reading the images in a blinded manner, and that's more unbiased than not. But that's not our philosophy here. We feel that as cardiologists, we need to look at the big picture. We're not just looking at the images. So we go over the clinical information of the patient, their stress results. Then we move to the findings in our imaging, be it calcium burden in the coronaries, other findings on the CT, our perfusion imaging, our LV sizes and function. And we get that whole picture of what we're getting out of the test. We then try to put that together at the end, sort of the final questions to the fellows after we have the results are, what are you going to do with this now? How are you going to manage this patient? Is this a patient in our emergency room? Is this an outpatient? Is this someone who's already had bypass and multiple stents? How are we going to take care of this patient knowing these results? So we try to go over the clinical implications of our findings. A little perfusion defect in an elderly patient who's really not having significant symptoms is quite different than a large defect in a young person who's debilitated. So we try to go over the sort of real world implications of our findings so that the fellows can learn to incorporate nuclear cardiology into their day-to-day practice. So that's what we do with each and every study, or at least we try to do it.
Thank you, Lane. SPECT and PET comparisons are inevitable. In what ways can SPECT still outperform or complement PET in today's imaging landscape?
It's a great question. I've lost a lot of hair and been here doing this a long time and started with SPECT and love SPECT. We jumped on the high efficiency and solid state bandwagon right when it started. And now over the last decade, I've done more and more PET and realized, the real strengths of PET. But I think, SPECT, its day is not done. I would go back to our first question and point out the availability of SPECT. It is so much more prevalent than PET that it's a true strength for the modality and is a way that it outperforms PET. You don't have to travel to a hospital. You don't have a long wait list to have your study done. You can get your SPECT done locally and quickly and with good quality results. So I think that's a real strength of SPECT. I think SPECT is good enough, old sodium iodide conventional SPECT. It gives you a good answer, and we have, years and years and years and thousands of patients worth of data to say this. But newer SPECT, which isn't so new now, but high efficiency solid state, is much closer to PET and image quality. And that's a real strength of the new camera technology that we shouldn't forget. And I think many of our patients these days, whether it's appropriate or not, they are really ordered to prove that someone is normal. And the clinical suspicion is unfortunately quite low for them, but the physicians want to exclude the disease. And, and a good quality SPECT can do that day in and day out. You don't need a more expensive, harder to get PET to give you a normal answer. SPECT can handle this majority of the workload, and then we can kind of reserve PET for our more difficult patients or more nuanced ones.
Thank you, Lane. Just a quick comment. Looking ahead, what innovations such as AI tools do you believe will significantly enhance the capabilities of a SPECT MPI?
Yeah, I'm by no means an AI expert, but I'm hopeful that as we incorporate AI into our practices, it can really help overcome some of the limitations that we have with SPECT. And I would envision AI as becoming sort of a pre-read for us for our studies, and that it can look at pre-read our perfusion results, our LV size and function. It can do a calcium score for us. We even have camera systems now that use AI for attenuation correction that doesn't exist. It's not done with a CT or scanning line source. So we're already seeing AI in action in that respect. But I think in the future, it's going to go a long way to helping us read our studies. It's going to provide that pre-read, that second opinion for us, and it's going to overcome some of the technical limitations that we have with our quality and our SPECT imaging. So I'm really enthusiastic about that.
Okay. Thank you. Talal, your last question, please.
A personal pearl, what's your one key piece of advice for someone starting a new SPECT lab today?
Great question. I think my one pearl would be that you want to invest the most in the training and education of your techs. That investment is more important and more valuable than any money that you're going to spend on the equipment, the software, the computers. Your techs are going to do the vast majority of the work for you, and they're going to be the most responsible for the quality of those images that you get out of your camera. So the amount of time and effort that you spend and invest in those techs are going to pay dividends far longer than the money that you're going to spend on your equipment. And that statement is true also for the staff that's going to perform your tests. You know, stress testing is really still much more of an art than it is a science. So that time that you invest in teaching people how to properly do the tests is also going to be of utmost importance and a very important investment.
Lane, thank you for participating in this episode of the ASNC interview series. We know that our listeners will benefit from your experience and insights. Thank you. And thanks also to ASNC, our listeners, and to Talal, my co-interviewer.
Thank you for your practical insights and your thoughtful perspective that you brought today. It was remarkable.
Oh, thank you so much for these very insightful questions, and it's been a real pleasure chatting with you all this morning.